Good afternoon, everybody. Welcome to Pediatric Grand Rounds. Dr. Hirsch sends his regrets he wasn't able to join us today, so it's my honor to welcome everybody at Grand Rounds and to introduce our speakers for today. Both are illustrious graduates of our own Pediatric Critical Care Fellowship program, although I don't think I personally can take any credit for their fantastic accomplishments and work in complex care, which is what they will be speaking about us today. Our two speakers are Duncan Henry. Duncan is a assistant professor, but not for long, I think almost associate professor of pediatrics in the Division of Critical Care Medicine. He's also the Associate Program Director for Assessment in the UCSF Pediatric Residency Program and serves as the Director of the Family Integrated Healthcare Transitions Program, which somehow gets abbreviated to FLIGHT. I've never totally understood how that works, but it does. A complex care and care coordination program for technology-dependent children. His academic career focus is actually on graduate medical education with a research focus on assessment and trustable professional activities and feedback. But today he's here to really talk about complex care. And for those of you who don't know Duncan as well as I do, he is one of those people who you really don't understand how he does it. He does an enormous amount of work for the complex care flight program, as well as for the residency program, and then is a fantastic clinician, a great colleague, and I understand that he actually also still has time for his children and lots of hobbies. I don't know how he does it, and he's always smiling and nice about it all. Our other speaker is Lindsay Brown, also a graduate of our Pediatric Critical Care Fellowship and even of our Pediatric Residency Program before that. So she's been at UCSF for quite a while. She focused her research work during Critical Care Fellowship on complex care children and has continued to work with this population as a clinician in our transitional care unit. She works in both the PICU and the transitional care unit. We were really quite lucky to keep her here. I think she secretly is trying to escape to the Pacific Northwest where her family is from. But this is one of the few blessings of the pandemic, is that as she graduated in the middle of the pandemic, we were able to convince her it was a very, very, very bad time to move. And as a result, she's still here. So without further ado, I'll give it over to Duncan. I think you're the first to take this on, right?
Yes, thanks, Andre. Let me just do this. Okay, hopefully that works for everybody. Thank you, Sandra, so much for the wonderful introduction and the two kind words for myself, and I suppose I'll answer for Lindsay as well. We're really honored to be here to talk today about complex care in general, but specifically what that means for UCSF. And I needed an alliterative sentence to really sort of bring our Grand Rounds presentation to the forefront. So problems, priorities, programs, and possibilities are what we'll be talking about. Just to say this, I have no conflict of interest to disclose, and neither does Lindsay for this. But I will be blatantly using this Grand Rounds to promote the need for an expansion of complex care services across our enterprise. And I'm going to show you some pictures and the families who have provided their written and verbal consent to have their pictures used in the process of this presentation. So this is just our objectives. We really want to help identify the population of children we will be discussing and talk about why defining and studying them as such is important to all of us. We also want to review the different models of care that have been developed to address the needs of this population. And at the end, we really want to review our own data here for a UCSF grown program and identify spaces for additional innovation and program development going forward. So I'm going to start by talking through a few terms and definitions that get used when we discuss medically complex or medically fragile children. The first, which I suspect many of you know, comes from work in the late 1990s to categorize and recognize that while the vast majority of children are healthy or have transient conditions, there's a percentage of that population that have a chronic condition. I put the definition up here, and I'll provide some more examples a little later on. But a child who might meet this definition would be someone with severe ADHD and would be referred to as a child with special healthcare needs. We should acknowledge that while this definition is helpful, there's also a lot of ambiguity here. A child with severe asthma might meet this definition, while a child with well-controlled or intermittent asthma may not require care, quote unquote, beyond that required by children generally. So in short, it's a start towards defining a population with higher healthcare needs, but doesn't quite get us to the specificity that some of the studies will show you have. So probably one of the most important definitions that we'll use today is the term children with medical complexity. The definition here gets more specific in that work done by Chris Feutner and others really helped define categories of disease and their corresponding subcategorization and ICD-10 codes to look at trends and databases among mortality across large groups of illnesses. So these complex chronic conditions, or CCCs, include large categories like respiratory conditions, and that might include cystic fibrosis, congenital respiratory malformations, and chronic respiratory disease. Layered onto this is an assessment of the impact of those diseases. Are they expected to last longer than a year, involve multiple organ systems, or require specialty care or increased healthcare utilization? Children who fall within this definitional framework represent an even smaller fraction of the pediatric population, and I'll show you some numbers and examples in the next few slides as well. And finally, just to put this up there, the last categorization that the literature involving complex care tends to use is identifying children with technology assistance or dependence. I always like quoting 1980s government research when I can. So this is just their definition that indicates that technology dependence is when a medical device is intended to compensate for a loss of a vital bodily function. So now that I've spent far too long on definitions, it's probably better to use some examples of the chronic illnesses that children have in these various categories. So in the first and most inclusive category of children and youth with special healthcare needs, we might find a child with severe asthma. But if that same child has not only asthma, but had cerebral palsy related to hypoxic injury at birth, the multitude of organ systems affected would classify them as a child with medical complexity. And if that child were to develop scoliosis because of their neuromuscular condition and require BiPAP, presumably at night, they'd then meet the definition for a technology-dependent child. For the purposes of this talk, we're really going to focus on the light blue and orange circles for the most part. So this is just another way of visualizing all those inputs that help define a child with medical complexity. And this comes from work by A.L. Cohen at Sick Kids in Toronto and really help flesh this out. I think in short, this image really helps note that it's not only the presence of a complex chronic condition, but also the fact that that complex chronic condition increases the needs of families caring for these children. They have increased healthcare use, and that there are maybe functional limitations that come along with the diagnoses that categorize children with medical complexity. So how many kids are we really talking about? I tried to piece the data together from a few different studies, but based on the references, you'll notice that I'm quoting things that started up in the late 90s to go to the early 2010s. And while these are all estimates, I think one take-home point that I want to make here is that the number of these children are changing and likely increasing. And in the next couple of slides, I'll show you about why that is. If we just look at the most inclusive category, again, children and youth with special healthcare needs, this is probably about 12.6 million children in the US, or about 1 million kids in California. But looking at children with medical complexity, we're talking about 6% of children, roughly speaking, and it goes down to about 68,000 children in California alone. I'd note that estimates for technology dependence and assistance are really hard. This study by Judy Palfrey really used census data from Massachusetts, and it's from the 1990s to try and make an estimate of what this is. But I would say that if you start to look at even more specific conditions like ventilator dependence, then it's even more a fraction of this, like 1/100%. And again, while these point estimates are helpful in understanding the quantity of children we're talking about, it's probably more informative to note that the number of children in all of these categories is increasing over time. And I just want to show a couple of examples why, but this is associated with improvements in care delivery in a number of areas. So just as an example, this is data from a 20-year review of trends in maternal and neonatal care, complications and mortality among extremely preterm infants born at neonatal research network centers. This is a little bit disconcerting for me that I'm quoting neonatology research, so bear with me. But it comes from a prospective registry of about 35,000 kids born between 22 and 28 weeks at 26 places across the US. And in the first figure, you can see that there's a general trend of increasing survival, particularly in the younger age groups of extremely premature infants. And so in this second figure, what I brought up here is related to the rates of morbidities. And while the rates of other morbidities in those kids declined, say late onset sepsis, or they stayed stable in say necrotizing enterocolitis, I draw your attention to the lower right-hand corner with bronchopulmonary dysplasia. I mention this because some fraction of these children will be classified as having severe BPD, meaning they'd have a need for more than 30% oxygen or positive pressure ventilation at 56 days postnatal age or discharge. And those kids would inherently be technology dependent and medically complex at the time of their discharge. So again, just to make myself sweat even more, I'm going to quote genetics literature, but this is just to point out that there's a similar trend towards survival in children born with congenital anomalies. This is a study from the Lancet that looked at a UK database of congenital anomalies and was able to have about 14,000 cases reported to it between the years of 1985 and 2003. And survival status was available for just under 11,000 of those live births. This first figure just shows some of the raw data that they have for a few of the categories and classifications for congenital anomalies, so I put that up there to confuse you. But perhaps most illustrative is a second figure that I have here. If you just look at congenital anomalies of the nervous system, you can see that most of the mortality related to these conditions occurs in the first year of life, and that children tend to survive many years after that. And as long as birth rates of children with congenital anomalies don't change, this means that we have a small but growing population of children with complex medical conditions that we're just adding to the pool. So I wanted to pivot to discuss why studying children who fit these definitions matter to different stakeholders, with the first focus being on the healthcare system. This is a study from Tamara Simon in Utah looking at changes to healthcare utilization metrics over time for inpatient admissions in children with one or more complex chronic conditions. It's a retrospective study that used the kids inpatient database at about 4 different time points. And what I think her findings really highlight is that the proportion of inpatient pediatric admissions, days, and charges all increased from 1997 to 2006 for the time periods that she had that data, for a child with any chronic complex condition and for every group of chronic complex conditions with the exception of hematology. Children with CCCs who were hospitalized accounted for just over 10% of admissions in 2006, yet their admissions accounted for 26% of all pediatric hospital days and 41% of pediatric hospital charges. I'm not showing you the data here, but they also accounted for 43% of deaths. The simple summary here is, despite being a small population, they are a significant driver of healthcare costs and use, and the more complex patients are, the more resources they use. So just to drive home the point even further, if we looked at ED utilization as another metric, we can see similar findings. This is a retrospective analysis done by Jay Berry in Boston that looked at almost 2 million ED visits in 2010 by 3 million children, ages 1 to 21 years across 10 states from a Medicaid database. The main outcome was the annual ED visit rate. And in short, although the overall annual rate was 569 visits per 1,000 enrollees, as the number of children's chronic conditions increased from 0 to more than 3, rates increased by 180%. And if you just looked at a section of children who were technology dependent, that meant that the rates in those children were 174% higher and compared to those without technology assistance. So putting this all together is when researchers talk about the economics of care for medically complex children, you hear these kinds of figures. About 6% of the population accounts for 1/3 of all pediatric healthcare costs, 1/4 of all hospital days, and just under half of all pediatric deaths. And it's not just costs that matter here as well. There are morbidities associated with having a complex chronic condition or being a child with medical complexity. We know this from the work that we do in our hospitals. These are the kids that we see more often and are frequently readmitted. They have higher rates of total and preventable adverse events, and there's variation in practice among institutions even within the same geographic region. So just to highlight points 1 and 3, I thought I would just pull in 2 more studies. So again, Jay Berry from Boston, a 2011 study looking at a cohort analysis of over 300,000 patients with 580,000 admissions over 37 children's hospitals from 2003 to 2008. The primary outcome here was the maximum number of readmissions experienced by each child within any 365-day interval. And tests for trends show that as the number of readmissions increased from 0 to 4 or more, the prevalence of a child in that category having a complex chronic condition increased from 22% for those who had no readmissions to 89% for those who had 4 or more readmissions. And similarly, I don't show this here, but for kids with technology assistance, in the 0 category, they went from comprising 5% of that population to over half of the population in those children who were admitted 4 or more times in a calendar year. And finally, it's interesting to note that there's wide variability in care for children with medical complexity. This is work by Sean Ralston at Dartmouth, who looked at a retrospective population-based observational cohort, I'll say that 10 times fast later on, using payer claims databases for children between 30 days and 18 years, living in Maine, New Hampshire, and Vermont between a 3-year period from 2007 to 2010. And it looked at those kids and their care and cohorted around the 6 hospitals that serve that region. After they adjusted for patient characteristics, they saw variability between institutions in how many ICU and inpatient days they were using, as well as how much imaging was employed and diagnostic test utilization. And what I think this tells us here is that there's wide variance in the way we care for children with medical complexity and opportunities to develop best practices and guidelines in the care for these types of children. So finally, I think we would be remiss if we didn't also pay attention to the impact that care of these children has on their caregivers. This is just a table from a systematic review that tried to pull on studies that looked at this particular lens of care and focused on parents of children with special healthcare needs and addressed the factors related to the physical and emotional work of providing care for these children. I think this table really breaks down the nature and scope of some of the work that's required for those family caregivers, whether it's in the day-to-day monitoring or management of a chronic condition, communicating to providers or to extended family about the child's condition, finding support for themselves or educating others or engaging in advocacy. I think any of these actions can be tolerable, but can move from beyond achievable work to a significant burden based on the number of tasks that family have, the nature of those tasks, and the context in which they need to be performed. So if we try to get a little bit more granular about the impact on families, I just wanted to highlight a few studies that shed some light on to what systems of care ask of family caregivers and the impact of those asks. Some of this data comes from a secondary analysis of a national survey of children with special healthcare needs done between 2005 and 2006. And I think the important points to pull out are among these: that caregivers of more complex children reported a median of 2 hours per week of working on care coordination, 11 to 20 hours per week on direct home care, that more than half of them reported financial problems, and a similar percentage reported that a family member stopped working because of the child's health. In a Canadian study where they compared caregivers of healthy children versus those with chronic conditions and asked about their relative symptoms and their own health, logistic regression showed that caregivers of children with health problems had more than twice the odds of reporting chronic conditions themselves, activity limitations, they had elevated depressive symptoms, and had greater odds of reporting poor general health than did caregivers of healthy children. So why is this happening? Here is where I think a picture is worth 1,000 words, and I talk about this when I meet with families or with our learners for the first time. This is a picture where a family participated in an exercise called care mapping, where they partnered with a family to describe key practitioners and services in their care. And it's essentially a pictorial representation of the challenges that these families face. What I tell our residents and our learners is that every single one of those lines represents a phone call that a family has to make, a transportation that they have to arrange, a refill to talk with a referring physician about. It's a form to fill out. It's a school meeting to attend. And on average, if you just start to look at some of this, these kids have approximately 14 physicians involved in their care from 6 different subspecialties. And the care coordination for these children inherently falls on families and primary care physicians. And particularly for the latter, training and support as well as financial incentives may be lacking. It requires integration from multiple electronic health records, emergency rooms, tertiary hospitals, primary care offices. And half of families with children with medical complexity identify an unmet medical service need, and a third of them experience difficulty in accessing non-medical services. I think most importantly is this is what this picture tells me. The system we have is currently set up to have fragmented, low quality care that is leading to high costs for children with medically complex and chronic conditions. It depends on families to be coordinators and care providers with very poor support for home care. And in short, our families are nurses, respiratory therapists, social workers, legal advocates, paratransit professionals, administrative assistants, in addition to being mothers, fathers, grandparents, or loving and extended family who care for this child. So I always appreciate an opportunity to quote work by our own Tom Bodenheimer. So I thought I would bring up his perspectives on complex care and care coordination. This is from his health policy report that not only outlined the challenges that are inherent with complex patients and systems, but highlighted the role that care coordination can and should play in such a system. I think in words, it makes the point that the picture I just showed you did. This need for care coordination has been taken up by others, including the American Academy of Pediatrics, who's provided policy statements on the value and necessity of patient and family-centered care, and particularly on care coordination for children with medical complexity. So I've provided a definition for care coordination that may be a little bit hard to read in the top portion of this figure, but I draw your attention to the lower right-hand corner about care coordination functions. And in calling out the need that they identify for things like separate visits, care coordination interactions, developing care plans, and management and tracking of referrals and outcomes, coaching our families in supporting their transitions in care, among others. These are all big asks. So to deliver these services, several models of complex care have been developed to try and address these issues. This is a nice review by Elizabeth Portis from Wisconsin that characterizes 3 different types of models that have come about, and most complex care systems that we see fit into one of them. Just to orient you, I briefly put some of the functions of the complex of the particular model up at just underneath the heading, and then some of the positive aspects of each type below. I think as we think about this, most of us are familiar and think of the primary care model almost immediately. This is the epitome of the patient-centered medical home, where it's a one-stop shop for everything from care coordination to preventative care and anticipatory guidance. Colorado Children's did this for Medicaid patients, and I'll walk you through some of their outcomes in the next slide. The second model is a consultative or co-management model where complex care tends to take on a specialist perspective in supporting the family, the primary care provider, or both, and becoming a single and hopefully easier access point to services that might be provided at academic medical centers. An example of this is Sick Kids in Toronto's, and I'll talk about their impact of their model as well. And finally, there are models that are episode-based, which are usually centered on long-term care of children or long-term transitions of care in facilities designed either to train families and caregivers on how to take care of technology-dependent children or to take on that role when necessary for extended or indefinite periods of time themselves. We have one long-term acute care facility here in Northern California that's a conglomeration of 2 to 3 different facilities that were formerly known as Children's Recovery Center and Saratoga Subacute, now rebranded as Children's Hospital of Northern California near San Jose. So I just wanted to quickly touch base on a couple of different models of care. I referenced the fact that Colorado developed a centralized primary care model situated within a tertiary care center. And similar to a lot of studies that look at this literature, this was a pre-post study looking at healthcare utilization and costs. They had 175 kids that they enrolled in this, and they created what they called a comprehensive primary care clinic. So this was physicians from a number of different backgrounds, nurse practitioners, social workers, and therapists, including physical, occupational, and respiratory therapists. And it also included additional services like case management and care coordination, and did some inpatient care for non-intensive admissions. They were particularly interested in healthcare costs and healthcare utilization, and they didn't see any significant differences in either the hospitalization or direct costs per patient for those who were hospitalized. But the average length of non-intensive unit care stay was lower after enrollment by about half. It dropped from 12 days to 5 days. And the children enrolled in the program also showed a higher rate of outpatient visits, doubling essentially from 51 to about 102 or so per 100 child years. So This is thinking about that next model that I described in co-management model outcomes. This is a brief overview of the outcomes for what they employed at sick kids. They developed a pediatric complex care clinic, which was staffed by a physician, usually from hospital medicine, and a nurse practitioner, and then provided logistical and medical support to primary care providers throughout the province of Ontario. They looked at several elements of their care delivery, including healthcare utilization metrics, as well as some survey-based data regarding parental health and family and primary care provider satisfaction with the services that they employed over a 12-month period. It's a pretty small study, and again, a pre-post design, but their impact was pretty notable. So they reduced total hospital days from a median of 43 to 15. They increased outpatient visits to specialty clinics, including their own complex care clinic, from 2 to 8. So quadrupling it, and an analysis of the parental health data showed statistically significant improvements in 3 domains of health-related quality of life surveys, including parental mental health. And thinking back to the impacts that we talked about for family caregivers, I think this has meaning and merit here. They also employed a qualitative component to the study, noting that there was still room for improvement, particularly in communication between the family and the team, the family and the PCP, or the team and the primary care provider, which I think we could all resonate with in our own institution here and our own practices. So finally, I thought I'd try to bring you to the holy grail of clinical research trials and highlight 2 studies that have been done within the last 10 years, the first in 2014, and this most recent one was published, I think, in 2021 or at the end of 2020. They're both from the University of Texas in Houston. The first was a randomized clinical trial of high-risk children with chronic illness who were randomized to either receive comprehensive care or usual care. And the enrollment was between a 2-year period of 2011 to 2013. The outcomes that they were interested in were children with serious health issues, including death, an ICU admission, or a hospital stay more than 7 days, the costs associated with those care, and then they looked at medical services that the children received, Medicaid payments, and medical school revenues and costs. Their intervention was a clinic that was open 40 hours a week and staffed by their medical director and 2 nurse practitioners. These individuals also provided on-call services 24 hours a day. A clinic was also staffed by a nutritionist and a social worker, and children were scheduled as needed to see a dedicated gastroenterologist, neurologist, or allergist and immunologist who attended the clinic once a month as well. In an intention to treat analysis, the comprehensive care model decreased the rate of children with serious illness from 22 per 100 child years to 10, and decreased the total hospital and clinic costs from over $26,000 per child year to $16,000. And they showed a reduction in emergency department visits as well as hospitalizations, ICU admissions dropped by about to a third, and number of hospital days dropping from 635 to 276. If I read the study correctly, and if you notice me sweating, it's because I'm reporting clinical data where I'm not an expert. They lost money in doing this, as Medicaid payments were reduced by about $6,000 per child year, and medical school losses increased by about $6,000 per child year as well. Their second study was a randomized quality improvement trial, again at University of Texas, that really looked at whether hospital consultation from complex care physicians could impact some of these same metrics. And just to tell you what their intervention was, that consultation included serial discussions between the complex care clinicians, ED physicians, and hospitalists, addressing need for admission, inpatient treatment, and transition back to outpatient care. Usual hospital care involved routine hospitalist care. They looked at total hospital days, PICU days, hospitalizations, and health system costs. And while they report probabilities for this, in short, their results suggest that they can reduce PICU days, they can reduce hospitalizations, total hospital days, and that again, they were saving the health system money by dropping total health system costs from about $42,000 per child year to $25,000 per child year. In short, in all of these models, some form of complex care is either associated with or directly responsible for reductions in healthcare utilization cost, and potentially associated with improved parental quality of life. And by the way, it comes at a cost to the health system serving these patients and families. So each of these programs I've talked about provide some or all of the elements noted here. And just to highlight a few things, Most of these programs focused on facilitating multidisciplinary team discussions about patient management. They coordinated and consolidated test procedures and appointments, and they provided some sort of support to families. So this isn't new to UCSF, and before I go on to our model of care, I really wanted to highlight the fact that many people, including many not pictured here, who participate in our multidisciplinary clinics, do some form of this work. Some of you may recognize Lucy Crane up in the top left-hand corner, a former chief of primary care and division chief who led the way for caring for technology-dependent children and children with cerebral palsy, both here at UCSF and as a national and local advocate. I'd really also like to note the effort and dedication that people like John Takayama at Mount Zion and Gina Lewis at Children's Oakland take both nationally and locally to provide a medical home for children in San Francisco and Oakland and to be leaders in advocacy as well. There are folks like Noemi Spinazzi at Oakland and Amy Whittle at the Zuckerberg's San Francisco General who lead clinics for children with Down syndrome who inherently have significant medical complexity and needs. And just before we took our stab at complex care for the larger community served by UCSF, we were fortunate enough to have guidance from Audrey Foster Barber, who really worked to bring complex care and palliative care together in a way for medically complex children that weren't immediately served in our surrounding area, but were served at a distance by our referrals to UCSF. So like any good young UCSF graduate, a group of us thought we knew better and we wanted to propose something different. So thanks to efforts by Ryan Pedrez and Priscilla Chan, among others, in early 2016, we launched the FLIGHT program. As Sandraine mentioned, we needed a good acronym that really confused people as to whether we were a transport agency or a complex care program. So we capitalized a few letters from Family Integrated Healthcare Transitions to create the FLIGHT program. And we created a bootleg logo that we can no longer officially use. So that's the only time you'll get to see it. Before I start talking specifically about FLIGHT, I really wanted to just note briefly how some of the impetus for what we were trying to solve came about. As a critical care fellow here and as a resident before that in Boston, I had seen this increasingly complex population, and in particular, children with ventilator dependence being cared for and staying for prolonged periods of time in our ICUs. And I was curious at the time whether there were family factors, particularly around how we taught and supported families caring for ventilator dependent children that might be attended to and where we could enhance discharge and help maintain their health in the home. This is just a colorful diagram of a process that Children's Colorado uses to achieve this. But the way I wanted to go about that was in a qualitative study, looking at caregivers and their learning experiences related to caring for ventilator-dependent children. With help from both Ryan Pedrez and Claire Gibson, one of our current chief residents, we interviewed about 15 caregivers of 10 children, and this is a bit of what we found. What we noticed was that families have a trajectory of learning over time in which they develop expertise and that there are distinct time periods where learning and needs are different. So one of the time points that we highlight is the index hospitalization, usually the time at which technology becomes a part of the child's life. It may be their first time and only time in the hospital, or maybe upon a readmission at some point for some chronic problem that they have. There's the transition home, and there's a period of developing mastery at home with those periods, the transition and the mastery period being punctuated by periods of readmission. Saying this another way, caregivers iteratively applied different learning modalities that are adapted to specific contexts and driven by situational necessity. So in the next few slides, I'm going to share some of the stories and quotes from each of these periods. So first, the index hospitalization. This marks the beginning of a caregiver's education, in particular, in this case, via the ventilator in their child. The initial learning is really procedurally focused, and though overwhelming, families really gain comfort and confidence through repeated and supervised hands-on practice with nurses and respiratory therapists. And the primary learning modality that they use here is an apprenticeship of sorts. For the majority of our families, the transition to home is what they would call controlled chaos. Learning here is a rapid cycle process driven by the fact that it's variable and time-sensitive logistics of integrating aspects of a formerly hospital environment in the home. Some families describe arriving home to a ventilator model different from the one they trained on in the hospital, and many describe the challenge of navigating the physical space of their homes, finding the right electrical outlets, positioning the child's bed with access on both sides, like the PICU, amongst other things. And all the while, what struck us was that the families really navigate this process alone. Previous resources and mentors from the hospital are more inaccessible, and they are forced to rely on their own survival skills in a process of trial and error. Finally, when the dust settles after the immediate transition home, caregiver learning enters this phase of developing mastery. They gain stability and expertise through a more focused, intentional process of developing a routine that involves future-oriented planning and focused problem solving. This allows families to individualize the care for their child. An example of focused problem solving that was shared with us was a mom who had a 60-minute commute that cost a major bridge to physician appointments here with her child. And so her husband, a mechanic at the time, figured out how to adapt a suction machine to their plug-in car lighter outlet so that she could provide suction while driving. This is not necessarily a recommendation that I provide to families, but I think speaks to their ingenuity. And another hallmark of this learning period is that the learner becomes the teacher of sorts. So that caregiver now takes on a teaching role. And many of our caregivers in the study that we did describe teaching others to care for their child, home nurses, school aides, and other family members. The quote that you see here is from a family who developed a set of laminated instructional cards with photos of their child and her BiPAP so that their child's teacher would know what to do in the school environment. This just reflects, I think, some of the take-home lessons that we had from families. We know that they actually have relative expertise in the day-to-day nature of the care of their children prior to discharge, but they have immediate and unmet needs in problem-solving that transition home and establishing a new set of services and a new team of providers within the home environment. We think that the majority of families will eventually develop expertise in all aspects of care coordination for their child, but really opportunities to support families in bending that learning curve upward appear often at times of transition, whether it's the first transition home, it's a transition to school, or it's a transition to adulthood, among others. And what we needed for our families was a way to meet these needs that didn't add to the substantial amount of care coordination that they were already providing. So how do we do that? Going back to flight now. We focus on 3 elements of care here. The biggest and largest pot is care coordination, and this involves everything from logistics of getting children to and from their appointments, to clustering appointments, to problem-solving durable medical equipment issues, amongst others. And I'm going to give you a case sort of series in just a second to talk about this. Our physician team focuses on a 30,000-foot view of kids and their trajectory in care as well. And then instead of thinking that we could do a better job of teaching families how to care for their children, we really felt that there's a space for us to help meet families and empower them to take ownership over the care coordination and to understand a fragmented system of care and advocate within it. So how did we do this? We initially trialed a model that involved an in-person clinic, an inpatient consultative service, an outpatient home visit program, some telehealth-based follow-up, and a 24/7 pager system, all with 3 and then 1 physician involved in that, which was not a sustainable solution. So our model now involves a consultative service on the inpatient side and telehealth-based follow-up for for both new patients and follow-up patients. We were doing about 75% of our visits via telehealth pre-COVID. Very rarely do we have in-person clinic visits because a lot of what we do, I think people would define as not necessarily medicine. So how do we define complex care? Who are the kids that flight takes care of? Well, we wanted to operationalize a few things that we talked about earlier on at this talk. We defined complexity as 4 or more specialty services here at UCSF who participate in active outpatient management. We define technology dependence as some piece of technology supporting a vital function in any of the following systems. And the reason we chose that is because those are all systems where families interact not only with the technology, but with a durable medical equipment company and likely a specialist who helps maintain that particular line of care. And finally, we identified that there was a need to not necessarily duplicate services that may have been provided in other wraparound ways. For example, our transplant teams take a truly holistic view of care of their child, and similarly for hem-onc or disease-specific entities like sickle cell. There are already care systems that do a lot of providing a medical home, and we wanted to find the kids who didn't have it. So this is just to say that there are a number of people who either volunteer their time or who have a bit of time supported by flight that include our case managers, program coordinators, a social worker, physicians, most notably Vidi Doshi is a MedPeds person down at China Basin who volunteers for our clinic. Camila, many of you know, is a former chief resident and was our inaugural fellow this year. And Stephanie Choi was our first resident to have a subspecialty clinic with flight. So I just wanted to walk you through a few slides of what we do on a day-to-day basis for our kids. So this is put together from a number of different patients, but sort of identifies some of the things that we do in caring for children with medical complexity. So pretty typically, we may receive a consult for request for complex care planning and care coordination. In this case, this was for a 1-year-old ex-premature infant with severe BPD and an anticipated need for long-term ventilatory support. So when we receive that initial consultation in the hospital, we join discussions about caring for a child with medical complexity with the team and also with the family, and would talk with them about decisions, including things like whether to pursue tracheostomy. We provided linkages to other families with trach and vent-dependent children to talk about the day-to-day aspects of care, and we reviewed options for discharge, including the need for home nursing or potentially transitioning to a long-term care facility. And we helped the team identify time points for medical stability, barriers that might be involved in prohibiting a timely discharge, identifying possible community supports like special needs daycares that exist in regional spaces, and follow-up needs, as well as locating and communicating with the PCP in their home community. And following that consultation, our case manager would follow along with the family teaching regarding the tracheostomy itself, and coordinated with the interprofessional team to make sure that it was complete by the time of discharge. Our case manager also checked in periodically regarding their readiness for discharge and with the intent of developing a relationship with the family. They are, again, our case managers engage in warm handoff with the inpatient case management and social work services to understand the status of and the nature of all referrals placed and supports identified. And our flight coordinator gets involved to cluster the first round of outpatient appointments prior to discharge itself. The team develops care coordination and access plans that provide not only a review of the child's medical history, but identify for the family with numbers of who to call for what and when and how to reach them. And once they go home, we do a phone follow-up within a day or two. And the questions are pretty simple. Are they getting settled? Have they started to develop a daily routine? Do they know where that access plan is? And we start to do some initial coaching, things like it's time to sort of get out of the house and try and take a trip around the block, knowing that that primary care visit is on the horizon in the next week or two. We identify that when a family isn't sure of who to call, we can be the first call for a family Monday through Friday with any durable medical equipment, medication, or care concerns. An example that might come up is that there were inadequate amount of trach supplies delivered, and we can help them coordinate or connect with their durable medical equipment company, or if not, help connect them with our pulmonologist to help problem solve the issue. Within the first month of being home, our flight case manager works with the family to determine their readiness for travel and identifies and problem solves transport issues. So you could imagine for a child traveling from Fresno to here, doing so with 4 oxygen tanks in the back of your truck may involve an incendiary device that probably shouldn't be on California freeways. And so in addition to that, we also help provide appointment reminders to PCPs and specialists, and our social worker engages the family to ensure that they've been establishing care and taking those calls from our community partners that might provide developmental or financial supports, or where we need to do some ongoing advocacy around home nursing. Finally, because I actually hadn't said that I did any work in this, we do some ongoing outpatient complex care management, and we do that through quarterly structured interprofessional visits. We'll problem solve equipment issues and medication refills. We'll try to address and route non-specialty illness concerns. We'll do some appointment clustering, and we'll do a lot of ongoing advocacy with our community partners, our schools, and nursing agencies. And we try to help address non-elective admissions and ED expecs, and more recently, we've been involved with the Prepare Clinic in providing some perioperative support as well. So I just wanted to make a few notes from this slide. This is sort of an annual look at our enrollment, and every year we work to expand our services, but have reached what we think the limit is for our complexity and our caseload, and now have a waiting list that varies between 3 and 10 patients at any given time. In this last year, we've become more intentional in graduating patients and created a step-down process that allows families to use us on an ad hoc basis. This is the flight stable category you see there. So in reality, we're serving about 65 patients right now. And the majority of our patients have 2 or more technologies that support them. So just in sort of broad categories, ventilator-dependent children have become an increasing proportion of the kids flight coordinates care for and are about 40% of our current census. And if you add in non-invasive mechanical ventilation supports like BiPAP, that takes those numbers over 60% of our kids. This is just a sort of redefining of what our roles are, but I'm going to skip over this relatively quickly and show you that where we provide care is the referral patterns for UCSF writ large. In short, we provide, this is where our 52 active patients live over 18 counties. I think our furthest distance is 350 some odd miles up to the Oregon border. We have extended into Nevada in the past. And I mentioned the 18 counties because each of those counties is its own little fiefdom of medical care and medical resources. Some have more than others. And so what we try to understand and develop is a regional understanding of the resources available in any child's community. So I'm going to stop there and kick it over to Lindsay, if that works. And so Lindsay, I'm going to put up your next slide and you can tell me when to advance.
Perfect. Can you hear me? Sorry, I didn't get a chance too much to check my, perfect. So Duncan sort of went through a bunch of different programs and then he explained what our program with Flight does. So I'm here to give a little bit of our outcome data that we collected over the past few years. And obviously, if you weren't proud of some of these numbers, I think I would have buried all of this and you wouldn't be hearing me today. So the pieces that I'll go over is a case control study to look at outcomes for all of the patients enrolled in Flight. We actually collected this data in 2018, so I guess it's getting a little bit out of date, but we collected detailed demographic and healthcare utilization data on all the Flight patients at that time, which was about 64. And then we also collected the same data on matched controls that were matched based on age and technology dependence. We did this using our VPS or virtual PICU systems database, which is a nationwide database that collects mostly inpatient metrics that most PICUs are a part of. And we looked at patients that were admitted to our pediatric ICU here at UCSF. And we looked at technology that they had on admission. So it was capturing their baseline technology dependence as opposed to something that might have been started during that acute admission. And then for outcome metrics, similar to some of the other studies, we looked at hospital admissions per patient years, hospital days per year, and hospital days per admission. And we also looked at some outpatient metrics, including subspecialty appointments per year and missed subspecialty appointments per year. So that was what we did amongst matched patient population. And then separately, we also looked at just the whole Flight population at large and did some linear regressions to try to identify within that population risk factors for increased healthcare utilization, just for our own knowledge and potentially for counseling families as well as they join Flight. So here in this table, we have baseline characteristics of our Flight and our control patients. Starting at the top, you can see our mean year was about 5 years old, a slight female predominance between in the Flight and the controls. And a fairly not a large non-white population, although a relatively large proportion of English speaking. Although I think Duncan and I could say anecdotally, there's probably an overrepresentation of English speaking in our patients' charts, where they may be somewhat proficient, but truly that may not be their primary language or their language that they would prefer to receive medical information in, but that's probably a piece of why that percentage is so high. Our Flight population did have a bit more public insurance than the controls, but as you would expect, the number of technologies was not significantly different. Our Flight population also had a slightly more complex chronic conditions compared to our controls. It did tend to be a little bit more complex. We collected data all the way back starting when we used the electronic medical system. So some of our controls had a lot more time that we were able to collect data for, which is why we defined all of our outcomes per patient year. And then just to speak, like Duncan had said, some of the stressors on families and our large catchment area here at UCSF, the median distance to UCSF for our Flight patients was 67 miles and nearly 50 for our control patients. So really are serving quite a large area. And then to get to some of the outcomes, the first few are the inpatient metrics, and the bolded ones are the ones that came out as statistically significant. So there wasn't really much of a difference in admissions per patient year, just under 2 in both groups, but the admissions tended to be shorter in our flight group, and quite a bit shorter, 6 days versus 17 days, which then led to fewer hospital days per year, a median of a little over 13 compared to over 30. Both of those were quite significant. And then for the outpatient data, and the number of subspecialty appointments was actually quite a bit higher in the flight kids, over 12 per year compared to over 7. But as Duncan said, a huge portion is trying to cohort those admission appointments, make sure families have reminders, adequate transportation to them. So despite having quite a bit more appointments, there was no difference in missed appointments per patient year. And then this last busy slide is looking just at the flight population and doing linear regressions to try to sort out if there were any predictors that were associated with the increased healthcare utilization, the same outcome metrics that we used on the previous slides. And that box highlighted in red is the only piece that came out as statistically significant when we looked at those different predictors of age, sex, race, English speaking. So the number of technologies there was significant. So for each increase in technology, you had about nearly 1 more admission per year and nearly 17 more days in the hospital per year. So I think that potentially could be useful when we think about talking with families about adding a new piece of technology. And that's been shown in other data that Duncan shared, but interestingly, some studies in the past have shown that just increasing complexity or increasing number of complex chronic conditions goes with more healthcare utilization. And in our flight population, we didn't see that. So that wasn't a statistically significant increase. So it seems that technology, at least for what we were studying, really was the big driver as opposed to just baseline complexity. Other things that, at least based on the data that we had, things like home nursing actually didn't show an increase or decrease in our patients' healthcare utilization.
Right. So I'm just going to talk a little bit about some recent innovations that we've tried to pursue in flight. The first has really been in thinking about complex care education. So this last year, we developed and piloted a pediatric complex care fellowship with support from the divisions of critical care, hospital medicine, and general pediatrics. Camila was our inaugural fellow this last year. We're on hold for next year, but we're hoping that we can recruit someone for the following year. So if anybody is watching this from neonatology, hospital medicine, critical care, or beyond, let's talk. And in addition to that, we've been partnering with other complex care physicians and some national family advocates to really develop a framework for curriculum and assessment in complex care, thinking about what a general pediatrician would need to know and also what a specialist in complex care might be required to understand and be proficient in. And then finally, this is not work that I've done. It's just simply being surrounded by wonderful people who have a lot of energy and effort. Alyssa Gutslitz has been participating in the master's program in health administration and interprofessional leadership here at UCSF and is piloting an annual multidisciplinary interprofessional team meetings for all of you with us to advance care and emergency planning for flight patients. So the idea here is that we bring the various subspecialists and surgeons together to think about what procedures need to happen over the next year, what their trajectory of care might be like, communication that we want to ensure the family has an understanding of around emergencies and contingency plans, and a general sort of perspective on whether our goals in that meeting align with the goals of care for the family. So just a few summary thoughts here. I think we as a greater UCSF community serve and will continue to serve an increasingly complex population that's only going to continue to grow. And models of complex care, including the one that we described today, can impact metrics that we care about for our healthcare system, our families, and our patients. For our current system For our current system here in California, I think telehealth is a conceivable means to expand these services and achieve some degree of capacity to reach most of our families. But I think as we think about expanding those services, it means more infrastructure to support patients and families. So this is my blatant ask for help. And at best, we are a break-even endeavor. There was a wonderful article written by Jay Barry in the Wall Street Journal that said, we're never going to be an entity that generates income for a hospital or health system. And most of the time we're a losing entity. Still, I think we should be doing this for all children of medical complexity cared for by UCSF who don't have a medical home. I realize that we can show the numbers that we do, in part because we're skimming off the top and taking the most complex kids that we possibly can find who may have the most need and trying to bend the curve there. Those numbers may start to decline as we have less and less complexity in the kids that we care for. Still, I think we can and should be at the forefront of innovation in care delivery, education, and research. This is just a place where it's, I recognize my own limitations. And I think there are smart, capable, and thoughtful individuals out there who have great ideas. And I welcome you to join us or to join with us to help us figure out how to care for these kids in new and innovative ways. So I just want to say thank you for your time. I'm going to skip the questions slide, but leave it for the end and just make a few quick acknowledgements. There are so many people that support this work, from my own division to people like Lee Atkins McAvoy and Karen Sun, to Stephen Wilson and Denart in the UCSF Health Leadership space, and fellow complexivists who've helped mentor me along the way as well. And because it's a grand rounds that I get to do, I'm also going to thank my beautiful and wonderful wife, who happens to be a respiratory therapist here and is the only reason I know what to do with a ventilator under most circumstances. So I'll go back to the questions slide and see if there's anything that you all want to hear us talk more about, and say thank you for this opportunity.
Thank you so much, Duncan and Lindsay, not only for this outstanding presentation, but also for all the fantastic work that goes into this. There's 2 questions on the Q&A so far. We have a few minutes, so if others have questions, we'll try to get through others. But the very first question comes from Dr. Lelkes, who says, thank you for this excellent presentation and for your work and dedication. You mentioned Audrey Foster Barber's work in alignment of complex care and palliative care. Can you speak a bit more about this interaction, both as it exists currently and also how you see it in an ideal system?
I guess I'll take this one on. Thanks, Efrat. I knew it was coming. I will say that in our experience, often the place where there's a huge amount of overlap is when children are on hospice. That a hospice agency functions very much like a complex care model, in that they take on as many possible aspects of care coordination as they can. I do think that as we think about the spectrum and the continuum of palliative care, there's a space for complex care to be sort of the nuts and bolts, the ideal back office for any number of specialists who are still involved in either symptom management or life prolonging exercises for those children. So I see it as a blended model that complex care sort of drops off as children move towards truly hospice-based care, but should be increased in children who have palliative care goals in mind, but still need supports.
The next question comes from another colleague of ours, Mindy Ju. Wonderful work, Duncan and Lindsay. Always amazed at your commitment to these children. Families are lucky to have this program. Her question is, what can we do to better advocate at a systems policy level for these children?
So you wanted me to get political. Lindsay, do you have a thought on this, or do you want me to go for it?
I'm not an advocacy expert, although I think there are probably a lot more attendees that know more than both of us that are on this call.
Yeah, first is like, talk to John. He can tell you what to do. He should be telling me what to do. A couple of quick thoughts. The first is that I think in a fee-for-service system and in a capitated service system like we have, even with Medi-Cal, where it's county by county fiefdoms, it's really hard to make a case with the 1 or 2 or 10 complex kids you have in any county that you can save them money by having them invest in a program like this. So frankly, we need accountable care organizations or universal health care to do cost sharing. The second piece is that we should probably invest in long-term care facilities to offload the challenges that our hospitals experience, so that we can actually create spaces for families that are family-centered, and we can train them and we can help them transition to home in a reasonable way that doesn't feel hurried, and that actually has clinicians wanting to do that work. And then I think, I guess on the advocacy end, we should all be asking for our policymakers to think of ways to support families financially for doing the work that they do. I think too much of the burden of care is still put on families. And even when we're in play, they're still experiencing significant amounts of stress and duress in the work that they do as well.
It's 1 o'clock, so I know that people will have to pull off and go to the next adventure in their Thursday afternoon. There is one more question and then one more expression of gratitude on the Q&A. But the question may be for people who have time to sit through this for just a little longer, I think is important. It's from Carol Miller, who asks, my work with CCS has highlighted the impact of caring for these children in vulnerable families. It's often seen more in the normal siblings and overall integrity of the family. Did you look at these issues in your survey?
Yeah, so first I'm remiss in not acknowledging that Carol has been doing this work for a long time as well in so many different ways. And Carol, it's a really great point. We did not in our surveys or in our own investigation. I think anecdotally, I can say that holds true for medically complex kids when there's a comparison to a normal child available in their home. I think it can cause quite a bit of duress and stress for families. But it's a really great point of something that we can and should continue to study in the future.
Well, it's 1:01, so I think I'm going to let people go. Thank you all again very much for attending, and thank you, Duncan and Lindsay, for sharing your work here and for all the work you do. Have a good rest of the afternoon.
Thanks, everyone.